Welcome everybody to our webinar, The Case for the General Dentist to Perform Orthodontics in a General Dental Practice. Before we start the webinar, we're using some new technology called Webinar Jam tonight. So if for some reason you disconnect, there's actually a reconnect button that you press on the top of your screen. So once again, tonight our webinar is The Case for the General Dentist to Perform Orthodontics in their own general dental practice. In this webinar, I'm going to discuss the reasons why a general dentist may actually be the best person to treat patients orthodontically. And if a general dentist decides to perform orthodontics, what does he need to know to ensure a high level of orthodontic outcome for his or her patient? And how and why the general dentist and orthodontist should collaborate with the care of all patients who are undergoing orthodontic therapy. So who am I? I'm Dr. Jeffrey Hall. I'm a specialist orthodontist and I graduated in orthodontics at the University of Pennsylvania back in 1990, so nearly 30 years ago. I came top of my class back in 1990 as a specialist orthodontist, and I don't say that from any part of arrogance in any way whatsoever. Because back in 1983, I did my dental training at Melbourne University, and I was probably in the bottom 10 of my class. And the point I'm going to be making out of all of this is that anyone can do orthodontics. Everybody's kept it as a closed shop, but orthodontics is actually very, very easy. So I've been a specialist orthodontist for nearly 30 years, completed over 10,000 cases. I was the first practitioner outside of the States to do Invisalign, and I've been really passionate about teaching general dentists since probably 1991. I founded the Seattle Study Club here in Melbourne, Australia. I founded the New Horizons Study Club, which many people will know, and I've also been the founder of Smilefast and now the founder of the OrthoED Institute, which basically specialises in training general dentists in this field of orthodontics. I've treated over 10,000 patients, so I've seen all the mistakes because I've made them all. And the question has been asked of me, why would a general dentist be the best person to look after orthodontic patients? So let's take a real paradigm shift and let's look at this really logically. Because a patient that comes into your practice usually has far more issues in dentistry than just straightening teeth. So let's look at this. How often do we see poor oral hygiene with braces on? And how often is this managed in an orthodontic practice? Very, very rarely. Because most orthodontists are just interested in straightening the teeth, but really there's a patient and there's teeth behind those braces. So I ask yourself the question, that's great to have straight teeth, but if they're going to look like they do on the right of the screen, I don't really think we've given that patient a great result. The best person to manage this on a visit-by-visit basis is the general dentist and their hygiene department. The orthodontist does not look at this. They might refer them back to the dentist, but a lot of our patients, as we know, think that once they're in the orthodontic practice, that they don't need to see the general dentist again, even if we as the orthodontist are referring these patients back. They have this mindset that the orthodontist should take care of it, which doesn't happen. But in a general dental practice, you would be on top of this day one. This is a really important aspect of their overall dental health. And you guys, as general dentists, are the best people to look after oral hygiene on a regular basis. This would never, ever happen if the general dentist was looking after the patient orthodontically, I can assure you. Happens very, very often and too often in an orthodontic practice. And then we have the periodontal maintenance. Patients who have got bone loss. And here we see a perio probe. And most orthodontists, unfortunately, do not even own a perio probe. And if they do own a perio probe, they use it to measure overbites and overjets, not to measure periodontal pockets. We're looking at the crowns of teeth. We don't look at the bony support. And once again, this should be done on a routine basis for every patient, and especially when we start to treat adult patients who are more likely to have some type of bone loss. Hence, once again, the general dentist is better to be managing this patient on a regular basis and checking the bone levels with the perio probe on a routine basis during any orthodontic treatment, because things can get out of control, especially if treatment goes for more than 6 months. And most orthodontic treatments, comprehensive cases that is, will go for 2 years of treatment. So serious problems and irreversible problems may occur over that period of time. You guys out there understand perio, you understand pockets, you understand how to manage these patients. And once again, who would be the best to manage these adult patients? A general dentist in their practice with that knowledge of perio and knowledge of maintenance of periodontal conditions. And here we see situations that occur because we as orthodontists, we keep moving the teeth, and here we are pre-orthodontically, and this is what it can look like post-orthodontically with recession that occurs. Now, this type of problem should have been picked up a lot earlier in treatment. And one could argue, hey, the teeth look straight, the bite, the occlusion's a bit better, but look at those lower canines, look at the lower anterior teeth. And yes, it can be treated with bone grafting, and we can get some nice results, but wouldn't have been a much better result if it was done far earlier in the treatment. And we have patients who turn out like this with that lower left central with severe bone loss, and more importantly, a dehiscence of that bone. And through orthodontics, we can improve that significantly by bringing the root back into the lingual plate of bone. And we've done that very successfully here. And in fact, we've overcorrected the root position. But if this was done in a general dental practice, we would have maintained this far, far better. Fortunately, this case was treated with great collaboration between myself as the orthodontist and the general dentist, and we actually brought in a periodontist as well. But it was strong collaboration. If this was done in the one practice, we wouldn't need the collaboration. And this patient was very fortunate that they had a strong team working together, but more importantly, that patient actually was happy to go to the other team members, which doesn't always happen in orthodontics. So it's the collaboration that's important in some of these cases, but this could have been done very simply in one's own practice. And then we have the endodontic issues that occur very commonly in orthodontics. And the most common is blunting of the roots. And this happens due to apical and sometimes even lateral resorption that occurs. And unfortunately, we as orthodontists, we take an OPG at the beginning of treatment. We may take an OPG at the end of treatment. I really know very few orthodontists that have periapical X-ray machines available to do intraoral radiographs. This could have been picked up on routine 6-monthly visits had they been in a general dental practice. Because once again, the patient normally feels that they've gone to another specialist, they don't need to see their general dentist. Even when we do everything in our power to get the patient back to the general dentist. This is just the perception. They don't want to spend any more money, etc., etc. If this was all done in a general dental practice, I guarantee at least 85% of these problems would never ever occur, because these would be monitored and assessed very quickly and treated appropriately. But when you get resorption like that, you've got to ask yourself, has that orthodontic treatment been really successful? Because now we have a long-term issue that you as the general dentist has to live with that patient, and it's nothing to do with what you've done. It's somebody else has done that problem. And now you've got to live with the consequences and not the orthodontist. And then we have restorative issues. And we have many different types of restorative issues. For example, we see very commonly patients who've got small lateral incisors. And how do we redistribute the space? When do we get them back to the general dentist to optimize the restorative work? And if this was all done in your practice, it will be a very simple situation. So what we do in our orthodontic practice, when we see our patients, we go ahead, we open up the space. So we open up the space and then we refer the patient back to the general dentist. We've got to take off the brackets off the small lateral incisors. We get the general dentist to build up the lateral incisors and we put the brackets back on. So we've now got 3 or 4 visits where this could be done all at one visit, chair side for the patient. The brackets removed, the tooth can be built up and the bracket replaced at the same time without going backwards and forwards. It's actually a much better service for the patient, and it means that you are in charge of exactly the right amount of space, because we hear that routinely from our clients saying, we've sent them off to the orthodontist, they've come back and there's not the correct amount of space. And we teach a very simple technique of how to do this routinely so everything is right and you will always get the right amount of space for your restorative requirements. So we'll build them up. So in essence, what we've done is we've created extra space. We've taken the bracket off. We've sent them back to the dentist. You've built up the teeth, and then we're going to close any of that residual space. And that way we know that we've got the right size at the end of treatment. And at this stage now, we've got all the right size. And it's all just now a very simple restorative approach. But this could have been avoided had the general dentist been in charge of the entire case. And then we've got the more difficult type of restorative therapy where we're going to be opening space for implants, etc. And once again, same problem. A general dentist, an orthodontist is going to open the space, but at the end of the day, the team leader is the last person in the scheme of treatment. So if this is a restorative case, the team leader is the restorative dentist. Hence, you should be very heavily involved in where those canines are going to be positioned, where the roots are going to be positioned in preparation for any type of restorative treatment, in this case being implants to replace the missing 12 and 22. So we go ahead and open the space, but once again, this can be easily performed in a general practice where you know exactly the amount of space that you want for your final restorative work, and whether you need to do any types of veneers on the central incisors to redistribute the spacing requirements. All of these reasons is why it's so much better that the general dentist is involved in the case, and more specifically, they should be doing the case and not having to refer back and forwards for these type of situations. But we can still get a nice result if we do great collaboration. And that's all great in theory. It's very difficult for everyone to collaborate absolutely perfectly. But if we do, we can get a great result. Obviously, collaboration isn't required when it's all done in the one practice. And that's the whole point that I'm getting at. You are in control of all of these parts, because at the end of the day, the most important thing is to achieve a great aesthetic and functional result, which is what you're going to be involved in with the restorative work, especially in a case like this in the anterior segment with placement of implants, etc., etc. And here we had a very nice result achieved just with the use of some Mary Lane bridges. And in the future, once she is finished growing, we can place the final implants. And then it comes down to retention, because orthodontists like different retainers. General dentists like to ensure that we've got good periodontal situations due to retainers. And at the end of the day, retention is going to be the part of the general dentist, because this patient is owned by the general dentist. So hence, whatever type of retention is used should be part of the general dentist's philosophy. Obviously, there are principles involved in the retention aspect, but whatever it be, retention is going to be in the hands of the general dentist, as you're going to be living with that patient for the rest of their lives. The orthodontists don't see the patients usually after 2 years of treatment. We call it demand recall. They're out of their practice and they're in the hands of the general dentist. Probably the most important part of treatment is retention, holding the result. Hence, the responsibility of getting the result should also lay with the person who's going to have to maintain that result, the general dentist. And then we have the great thing that goes on called the referral merry-go-round. And this is what patients hate. This is what general dentists hate. They go to the orthodontist, and the orthodontist refers them to their colleague, the periodontist. The periodontist refers them to the colleague, the prosthodontist. Maybe the endodontist gets involved. They go around to all these different people. And you know what? They're burnt out by that stage. They are totally burnt out with seeing all these specialists, and they never go back and see the general dentist again. And do you think that's doing a great service for the patient? Not at all. Because at the end of the day, it's the long-term relationship and control and guidance of their general dental health that is most important, and that relies on you guys as the general dentist. So we want to get rid of this referral merry-go-round. Nobody likes it. The patients don't like it. The general dentist yourself doesn't like it. And we as specialists don't like it either, because we lose track of where they're at. Are they with the periodontist? Are they with the prosthodontist? And we just have to wait to hear from the patient again. So it's really important that we try to get rid of this referral merry-go-round, because it's not a practice builder and it's not good for dentistry in general. And then the most important part is the patient who is referred to me as an orthodontist, and they come via you as the general dentist. You are the ones who've got their trust. They identify with you. They've built up loyalty to you. And it's that trust which is so important. It's no different when we buy a house with a real estate agent. Whatever we do in life, we need to have trust. And you are the people where the patients have their trust. Not in us as a specialist, but you've put up their trust over usually many, many, many years. And they actually do not want to leave your practice. You hear it all the time. Can't you do it? You guys do endo. You guys do perio. You guys do oral surgery. You place your own implants. And they trust you to do that. You don't necessarily refer that off to a specialist. And most orthodontics, as you're going to see, does not require a specialist. So in summary, the reasons that a general dentist should be doing orthodontics, and in fact, in some ways, are the best person to be doing the orthodontics. Those patients who've got perio and oral hygiene problems, or who develop those type of problems during treatment and are not managed accordingly. Those patients who need restorative work at the end of treatment, be it veneers, be it build-up teeth, be it implants, whatever it be, because it's the general dentist, therefore, would be the team leader in this, and they need to know exactly where the teeth have to be at the end of treatment. And then we have this burden of long-term retention, which is in the hands of the general practitioner already. So let it be in the hands of the GP who's done the treatment and who's provided the right retainer that they feel will be appropriate for that patient long-term. And then from a practice management point of view, we want to reduce referrals out. So what a lot of practice management consultants refer to as practice churn, and increase patient retention. Because at the end of the day, that's just income that's being lost. I mean, how many of you refer out an upper central incisor endo? How many people refer out basic perio? And that should be the same with orthodontics. You can get to a level that you should only refer out those really exceptionally difficult cases, not the general standard case. My orthodontic colleagues get upset with me because traditionally the reason why orthodontists have done quite well is because it swings and roundabouts, and we rely on the easy cases. And what we need to do as orthodontists, is reduce the number of patients that we see improve our quality of care, and yes, charge more for our orthodontic treatment, just like the endodontists charge more. I have no problems with that. And you guys should be seeing the more simple cases. We've got to get rid of that referral merry-go-round. And I'm sure that as we get older and we spend more time in dentistry, dentistry can become a bit of a bore. It lacks challenges because you get pretty good at doing class 1 amalgams or get pretty good at doing crown preps. So orthodontics now can provide you with this extra challenge in dentistry and really provide a lot of enjoyment, because there is nothing better than to see what you're doing for a patient, from going from crooked teeth to straight teeth, improving their smile. And what most patients say to us, we're providing more confidence. We're improving their self-confidence. And that's what it's all about. And lastly, and quite importantly, it's a way of increasing your income. And we're all out there to have a good living. So there's nothing wrong with increasing your income. And orthodontics can offer that as a new area of dentistry in your practice, even provide you with a new referral mechanism in your practice. You can now start to treat more children, and these children, you'll treat their parents, etc. You might start doing adult orthodontics, and that brings in the children as well. So it all becomes a domino effect to increase the size of your practice, increase your income, and probably most importantly, improve the quality of your clientele. So let's discuss the cases that you can treat with minimal training, the cases that you might need more extensive training, and there are cases that you don't want to treat, and why. And there are cases that need to be referred out, no different to endodontic cases. You don't want to be doing a endo on an upper right wisdom tooth. You may want to, but very few people do. You don't want to be doing sinus lifting or bone grafting, but you can put in the simple moderate implant cases without a problem at all. So the question is, do you need to be an orthodontist? And the answer to that is absolutely no. For about 7 years, we've been training doctors in our short-term orthodontic approach that we call Smilefast. And I'm going to show you cases that these clients of mine who are all general dentists and they had no previous orthodontic experience. And what we did, we provided them with a 2-day orthodontic program with really sound orthodontic principles, plus ongoing support. So a whole mentorship program. So with minimal training, with 2 days of orthodontic training, we choose the right cases, we teach you the right mechanics, the right diagnosis, and basically the traditional keys to clinical orthodontic treatment was diagnosis and which cases to treat, and most importantly, which cases not to treat. Bracket placement, how do we position those brackets? And we have a technique which is a digital indirect bonding, which makes it even easier for people. And then we've got to teach certain mechanics. How do we move the teeth? And that's actually very, very simple if we treat the right cases. So this was a case treated by one of our dentists, 2 days worth of training, no other experience, never did orthodontics before. And they put our Smilefast braces on, and in 7 months, they aligned the teeth. With no training whatsoever, they saw the patient once a month, and they made a very good hourly rate of probably over $700 or $800 an hour. So comparison before and after 7 months of treatment. Not a bad result. I'm sure people out there who've never done orthodontics don't believe that this could happen. This happens routinely. This patient was treated in 6 months with some spacing on the upper and lower and an edge-to-edge bite. So I ask you, how could you treat this patient restoratively? And what tends to happen is if you don't do any orthodontics and you refer them to the orthodontist, and the orthodontist says, well, it's going to be 2 years of braces and rubber bands, etc., most adult patients will say no to it. But you can treat some of these cases in 6 months. This is exactly what our doctor did with no training whatsoever. A deep bite case. So here we are, just lining up the teeth. Yeah, and that was in 7 months of treatment. Not a perfect result, but I tell you what, compare it to a veneer case. How could you treat this patient with veneers? How thick would you make them? So by doing orthodontics, we've now improved this situation significantly in a short period of time. And this is only after 2 days worth of training. And one of the keys to all of this is bracket positioning, and we use a digital indirect bonding setup where we can place the brackets in the digital world on the maloccluded model, and we can see approximately, and very, 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 very approximately, in other words, very, very good indeed, what the expected outcome will be by placing our orthodontic wires and having those wires become straight. So that's how. So this patient was treated in 8 months, before and after. Here we are. These are the initial photos, just some mold spacing in the lower, some mold spacing in the upper. Not a difficult case whatsoever. Really could have been a great case for aligner therapy, when you look back on it. But in 6 months, looks fantastic. Patient really happy, occlusion great, bonded retainers in place, and the dentist decided what bonded retainers they should be, because the dentist is the one who's going to be managing retention for life. So the final picture, not a bad result. And once again, all done with digital indirect bonding. So we take one of the difficult parts of our training and our learning out of the equation. Probably no different when you think about it to putting in implants and using a digital stent, because we take that difficult part of out of the equation and make it very, very simple. So to finish off with these type of cases, we've got a lot of crowding of the upper, quite a bit of crowding of the lower, and this patient went off to an orthodontist, but once again preferred to be seen and treated by the general dentist who's been looking after them for 15 years and have built up that big trust factor. So here we are with the digital setup, or the digital bracket positioning, which is a very accurate bracket positioning. And then these are just placed with indirect bonding trays, and that's basically like etching and bonding and just holding a bleaching tray in place. So your chairside time of actually physically putting the brackets on with these type of cases is probably about 3 minutes. So if you run with hygienists, oh my God, you can do this in a really efficient manner. And then we debanded them, and that was about 7-8 months of treatment. And it looks pretty close to what we expected it to look like with the digital indirect bonding. And they've actually built up that 1-2 with the veneer. That's why we actually intruded that tooth from the orthodontic point of view. And once again, the reason is that the dentist had the plan in place for the restorative work. That's why the dentist is the best person to be treating these patients. So 7 months of treatment, very nice result for 7 months of treatment. Patients are ecstatic. And if you want something which is a practice builder, make people's teeth straight very quickly. That is the greatest practice builder that you can have. A more severe case, and not a perfect result, but in 6 months, now you can go ahead and do whatever veneers or restorative work and do minimally invasive dentistry. And that's what it's all about, be able to provide minimally invasive dentistry. So it's not to say they won't need restorative work, but you can do this in conjunction. Because I would argue with you, and I'm sure there's no argument here, how would you go ahead and veneer that upper right central without actually devitalizing that tooth? And now let's look at cases that you can treat with just some more extensive training. And I'm not talking about doing a master's degree and being at university. You can do this through probably 20 days worth of education. And we'll talk about that later. So it's not a lot of training that you need, but you do need a bit more extensive training. So you can do these cases with very deep overbites. And this would have been 18 months of treatment. Deep overbite class 2 malocclusion, significant crowding. This case would have been about 20 months of treatment. Case with anterior crossbite, crowding, and we would have had to do extractions for this patient. And this was done in 18 months of treatment. Patient a adolescent with a severe class 2. This was done in 3 years of treatment because it needed a functional appliance first, and then once we corrected the class 2 to a class 1, which was very, very simple, we just needed braces to do the fine tuning. Anyone can do this, anyone. And then we've got patients who are probably a little bit more involved here, where they might need some surgery as well, but once again, very simple. So this patient needed some palatal expansion with some surgical assistance here, and then orthodontics. And this was done in 21 months. So you've actually improved him from aesthetically, significantly, functionally. He's now functional, and he's a very happy person because of that phrase, increased self-confidence. And we hear that time and time and time again from our patients and our patients' parents. They come and say, 5 years later, I loved what you did because my child now has greater self-confidence. And that's what it's all about. So deep bite cases, which can be severely dysfunctional with wearing away of teeth, etc., done in 21 months. Just upper and lower braces. Once again, anyone can do this. You don't have to be an orthodontist at all. And early treatment cases here with some severe crowding, all treated with 2 phases of therapy. The first phase with some RPE and some upper braces to get some extra space, and then a second phase with full braces. Once again, a early treatment done, and this is just the end of the first phase of treatment, just with some palatal expansion therapy and some partial braces. So you can see the increase in the width of the upper jaw, which would have helped in the airways, which would help in the smile, and patients are very, very happy. This kid was, I think, 10 years of age when they first presented, and they'd seen 4 other orthodontists, and all of the orthodontists suggested orthodontic surgery. This was treated non-surgically. And this can be taught to you how to do that. And I'm not saying every case can be treated non-surgically as a class 3, but you'll be surprised at how many can be treated non-surgically if we get them at the right time. You'll be quite amazed. And there are cases, unfortunately, that you don't want to treat. For example, this boy comes in and you can see here he's got what we call a dolichofacial tendency, and he's got already a class 3 tendency. So, and an anterior open bite, you can see he's a bit class 3 on both sides, and we thought we could treat him. And so we went ahead and we treated him orthodontically. Looks fantastic. I think everybody would agree. It looks fantastic. 6 years later, he's grown. The class 3s can grow. He's got a cant that's occurred. 6 years later, do we treat him now? We want to make sure that you've finished any growth, because the last thing we want to do is to treat him again and he ends up growing out of it. But so we treated him with a combination of braces and surgery. So we put braces on to what we call decompensate him. We make him look worse before we make him look better. But this is all very simple. In fact, the surgical cases can be the easiest, because all you're doing from an orthodontic point of view is aligning the teeth. And now the surgeon moves the jaws together and puts the jaws in the right position. So all the hard work really is done by the surgeon. So that's what he looks like after the jaw surgery. You've just put the teeth in the right position over the basal bone, and now the surgeon comes in and puts the jaws together. And so you look at that and go, hey, that's not a bad result. And we just hope that he doesn't continue growing. So there are cases that you don't want to treat, these severe skeletal problems that may continue to grow. And we have an expression in our OrthoED Mini Masters program, pick the low-lying fruit. You don't want to treat 100% of your patients. You want to treat 100% of the patients that you want to treat. And I think that's really important, not just in orthodontics, but in everything in dentistry. because it's always that patient that you go, I wish I never started them, that ruins your day. And that's where specialists are great for. Send them the more challenging patients. That's what we should be doing. You guys should be doing the simple stuff. And most of it is simple. And then we've got this patient, once again. So we've got an impacted canine here. Now, this patient came to me and they had been treated, I think it was over in India, if I'm not mistaken. So when they came, the orthodontist had been trying to pull in this impacted canine and kept on pulling it in, and the gum had actually overgrown again. So we re-exposed the canine. This is one that I would have said, I wish I never started treatment. So, because I thought I must be better than the other orthodontist. Have you ever had a case where they come in from a general dentist, it's failed from one of your colleagues, and you think, well, I'm going to take it on because I'm better than the other person? Usually that's not the case. Usually there's a reason, and I didn't understand this. So I started putting traction to this particular canine. So I started pulling down the canine. It overgrew again, the gingiva. So I started pulling it down, and then I started to engage it. And you can start to see now there's a little canter developing as I tied in that upper left canine. I'm thinking it's okay. I've done a good job. It's moved a long way. And then look what happens. That canine becomes ankylosed during treatment. And look at the cant that's developed. Everything is moving to that ankylosed tooth. No, not too dissimilar as if we tied an implant in. That tooth's not going to move, so everything else moves to that tooth. This is when you start to say, I wish I never started the case. And here we are. So we're trying to realign, and I'm trying to get out of damage control. And I actually end up pulling the tooth down. I couldn't get it down all the way, but I used my restorative dentist to build up that canine. So I got it down probably 85%, and enough was enough for everybody. And the rest of it, I fixed up purely restoratively. And that's one of the great advantages of you guys as general dentists doing orthodontics. There are all these little things that we as orthodontists, we spend months and months or an extra 9 months pulling down a tooth, doing something, and all we're doing is causing more harm than good. We've got greater chance of root resorption, greater chance of perio, etc., etc. And all you may need to do is do a simple composite, a simple veneer, something, and we can deband that patient. But once again, if you're in charge of that, you would find the simple way as that patient's coming back. Because every time the patient comes to us as the orthodontist, we'll just keep on pulling on that tooth and pulling on that tooth. And I think so many times the patient is so much better served by the general dentist doing the treatment for those reasons. So we've got an acceptable result considering that canine was right up in the palate, but not perfect, but a lot better than where it was. So the keys to orthodontics in a general practice, what you need to know and what people don't tell you. The traditional keys to clinical orthodontic treatment: diagnosis, which cases to treat and which not to treat; bracket placement; and mechanics. That's what we went through earlier on in the webinar. They were the traditional keys. As we as orthodontists, that's what we were taught. Get the right diagnosis, decide which cases we're going to treat. Unfortunately, we have to treat every case, but for you guys in general dentistry, you decide which cases you're going to treat and which you're not. You're in a much better space in that way, because you can decide to treat the easy cases, even the moderate cases, and refer off the severe cases. We have to teach you bracket placement and mechanics, and that's what we do as orthodontists. However, I believe there are more keys than those three to doing successful orthodontics, especially in a general practice. And the first key is obviously training and knowledge in diagnosis and treatment plan. The second key, which most people do not do, and I include orthodontic colleagues in this, is proper case risk management. And this requires a real knowledge of biomechanics, etc. And this is something that I'm really, really passionate about. And then you need efficient, predictable, and sound mechanics. Not cookbook stuff. We can treat cookbooks to about 75%, but you need to understand the mechanics. And that's not difficult once you understand the biomechanics. And to be really successful, no different to being a good dentist, doing endo, you need a good mentor, and you need it in an ongoing way. So you need ongoing mentorship so you can become comfortable and confident. And then to make this efficient in your practice, you need an efficient process flow. So from new patient to deband to retention. No different to how you do an endo. You would have steps and stages that you would go through. Okay. And you need to do the same in orthodontics, and we need to help you with that. And then we need to develop clinical and administratively efficient systems for the different types of treatment. And I'm sure you've got the same thing that you do in general dentistry. Whether you're doing a crown, you're going to have a different clinical system and a different administrative system to doing an implant. So in orthodontics, you might be doing early treatment, and you might be using a functional appliance, or early treatment using an RPE, or you might be having full treatment or surgical case. Whatever it be, we have to develop systems for each of these different treatment types. And then we need to train you and your staff. And if you really want to make this profitable, you need efficient delegation. We need to delegate it to those auxiliaries who are allowed to do procedures. For example, the hygienists and the therapists. But you can delegate photography, you can delegate intraoral scanning, you can delegate instructions to your nursing staff. And at the end of the day, when you do all this, we want maximum profitability with minimal stress. And these are the keys to a successful orthodontic practice. These are the keys to successful orthodontics in a practice, especially a general dental practice. No different in an orthodontic practice, I might add. So, training and knowledge in diagnosis and clinical treatment. An investment in knowledge pays the best interest. Benjamin Franklin said that. And I love this quote by John Dewey. Education is not preparation for life. Education is life itself. Do you believe that you've learned everything in dentistry after you finish dental school? Not at all. All it's done is given you a license that you don't kill somebody, hopefully. And now you've got to start to learn everything. So let's just run through this very quickly. Case risk management, because this is a real passion of mine, something that very few people I know even understand it, and less people even teach it properly. So here we are where this is a really difficult case, and there are reasons for it biomechanically, which you need to understand. And these are all the biomechanics that goes on. It looks very complicated. It's actually quite simple when you understand the principles. But as you bring down those canines, you're going to get intrusion of the adjacent teeth. If you get intrusion of your incisors, you're going to get proclination of those teeth, and they're already proclined. The bite's going to open even further. So there's all these reciprocal side effects that go on, and we need to know what they are and how to manage them. These are the 20% of the difficult patients I'm talking about. These are the 20% that don't fit into that cookbook approach. So, and this proves to you how stupid we can be as orthodontists. I went ahead and I put up braces on every tooth. I go, isn't this fantastic? I got the braces on, put the wires in, and look what happens. I developed that type of occlusion in about 8 weeks because of those reciprocal side effects that occur. So it's not always the correct way to put all the brackets on at once. And we have to show you which cases to do. Why did that happen? And there were plenty of different reasons why it happened. But this is where knowledge comes in. And this is a really interesting case because I thought I was really good. I was able to put a bracket on this lower right lateral incisor. I think, aren't I really good? And look what happens when I do that. Look what happens to the premolar tooth. It moves out even further buccally. So it's a reciprocal side effect that occurs because of the way I've done the wire. So this whole concept of putting braces on every tooth can be really bad. This cost me 9 months of treatment to fix up that one mistake. And this is the reason why most orthodontics takes 2 years to treat. You can actually treat most patients in 12, 15 months if you know what you're doing. But most of the time we spend in fixing up problems that should never have happened in the first place. And one of my mentors, Ron Coney, said 25% of what we do in orthodontics is redoing stuff that should never have been done in the first place. And that's what happens. And this is risk management. And I really teach this very thoroughly. And to give you an idea, if you've got good diagnosis, good treatment planning, and good staging of treatment, where knowledge is power, similar patient to the one you saw before, where the open bite developed, etc. 4 months in treatment, and everything's under control. We've just got some spaces to close up. We've taken out some teeth. We've closed up most of the spaces all in 4 months. This patient will be finished in probably 12 to 15 months of total treatment time. But that's if you understand exactly what we're talking about. And that's if you understand risk management. So training and knowledge and risk assessment, it's no different with braces to aligner treatment. So this is a case of an open bite that I was asked to look at by one of my clients. And so Invisalign came back with this setup. So it was, and what they do is they intrude the posterior teeth, etc., and then they do a bite, then they do this bite jump and it looks great, looks absolutely fantastic. I looked at that and said, it's never going to work. The attachments are in the wrong spot because they don't understand the biomechanics. We need overcorrections, etc. So this was wrong. That was treatment plan 1 that Invisalign gave the dentist, and I said, no, it's wrong. So I did 2 other treatment plans, and this is how I finished the setup. With that much of an open bite, with attachments on all these other teeth to counteract the reciprocal side effects of the extrusion of certain teeth. So here we are with doing a lot of intrusion of the posterior teeth, and here's the bite jump that will occur. So I'm trying to overcorrect it. This will not happen clinically. I'll probably end up with about a 1 millimeter overbite when I'm finished. But with the previous case, with the previous treatment plan, it's treatment plan number 1, I would have ended up with actually still probably a 3 millimeter anterior open bite. Hence, the understanding of biomechanics is as important with aligner therapy as it is with fixed braces. And people think you get this pretty picture, and I call this cartoon odontics. And if you speak to the people who know a lot about Invisalign, they'll say the same thing. So you need to understand what you're doing. At some point, you're going to need a process flow, and I'm not going to go through this, but in our practice, we've got a process flow. We can help you with all of this, which goes from step 1, when the patient phones up, for every appointment, step 2, all the way through to step 3, step 4, the follow-up letter, everything's documented. The tasks are all ticked off. So that way, any staff member, and especially any new staff member, will know exactly what that process flow is for every patient. And then we need to set up what I said before was clinically and administratively efficient systems for different treatment types. So we have clinical systems for indirect bonding, for direct bonding, for the placement of bands. So every procedure needs to have a clinical system, including tray setup, etc. No different to how you do endodontics. You would have a clinical system for everything you do in your practice. You may not write it down, but you do it so often, that's how you've trained your staff. Whilst you're learning something new, you need to write it down, and we need to train people on it. So we can provide you with all the clinical systems to make orthodontics efficient, predictable, and profitable to you. And then we need the admin systems. So we have Excel spreadsheets, we have contracts, we have informed consent, we have information about each of the appliances. So we have all of that ready to go. And then we need to train your staff and teach you how to delegate efficiently. Because at the end of the day, the great thing about orthodontics is the one area where you can delegate 95%. Orthodontics is a thinking game. All you got to do is understand what's going on and tell people what to do. And the rest is really easy because you can train a monkey to do the actual technical part of orthodontics. It is what, gluing a bracket on the tooth in the right position, tying in a wire. Is that tough? In fact, most of the auxiliary, all the hygienists that I've used, tie wires in better than I do. And then another part, if you really want to take it to the next level, is to learn how to schedule in your practice, because you need to template your schedule, and we can help you how to template schedules in conjunction with general practice requirements as well as orthodontics. If you start to throw things everywhere, and the same would apply to your general dental work, you will be in an absolute mess without your daily production that you need to make your income. You'll be busy but not productive. So we have templates that we use in orthodontics, and we've modified those and work with you to make those templates successful when you incorporate orthodontics. And you might have to change those templates as you become busier in the practice and you need more banding times, you need more adjustments. But we can do that because that's really one of my great areas of expertise. So what you need to be clinically successful and how to incorporate orthodontics efficiently, predictably, and profitably into a general practice. You need, one, a great orthodontic course. And how do you assess the best orthodontic course for you? Well, firstly, you need to obtain the correct knowledge. You really want a specialist orthodontist to be training you. You want to learn the full gamut of orthodontic education, not just aligners, not just early treatment. You want to learn everything that you can because they all dovetail into each other. Diagnosis is the key, and that is important whether you're doing aligner therapy or whether you're doing early treatment. So you need the full gamut. You need hands-on experience. So you need a program that's actually going to be hands-on as well. You need mentorship. You need somebody that you can trust, just like your patients trust you. You need somebody that you can trust to be your mentor and guide you, that you can be on the phone to, that you can be on a Zoom call, like a Skype call. And you want to have a situation of ongoing learning, because learning never stops. So even if you did a 2-year program, there will always be updates, and you need ongoing learning. So, as you know, I founded the OrthoED Mini Masters after we did Smilefast, and it's been really interesting for me, and we've really loved it. And we have been told by our clients that it is the most trusted and comprehensive orthodontic program that's available today for general dentists. So we do 8 core modules, and 8 core modules I think goes over about 21 days, and the modules range from 2 days, and module 2 is actually broken down into 4 days, 2 lots of 2 days. So most of them are 2 days, or most of them are about 2.5 days. Some are 3 days. And then we have an optional module 9, which is a staff training program. And we have that with Jesse Green, Peter Sheridan, and Robin Wood, which is a fantastic program to actually start to bring your staff into it all. But module 1's on diagnosis for 3 days. Module 2 is what I call conventional and unconventional straight wire mechanics, where we talk about orthodontic biomechanics, new patient exam, ideal case finishing. That's two lots of 2 days. Module 3 is early orthodontic treatment, 2.5 days. Module 4 is aligner therapy for 2 days. Module 5, we talk about accelerated and aesthetic orthodontics, and we talk about sleep apnea and TMJ with special guest lecturers. Module 6, is 2.5 days on really advanced biomechanics, management of class 1 malocclusions, both non-extraction and extraction, management of class 2 malocclusions, both extraction and non-extraction. Module 7, we talk about management of severe dental and skeletal discrepancies, including orthodontic surgeon, and we bring in an orthodontic surgeon as well to discuss that in more detail. That's 2.5 days. Module 8 is our sort of finale, which is our interdisciplinary approach and management of really difficult orthodontic problems, such as impacted teeth, such as transposed teeth, orthoperio, about 2.5 days. and we bring in a prosthodontist, Andrew Dillon, where we do a joint presentation on these severe IDT cases. And I've just spoken to you about Module 9. So the general outline, 2 to 4 days per module of face-to-face lectures. It is really sound and comprehensive orthodontic training. We do treatment planning exercises at each module, and we give you treatment plans to do beforehand, and then we do group discussions. So 1.5 hours of each module spent on treatment planning. We do individual problem shooting. We bring in guest lecturers who are experts in specific areas where applicable. For example, we have Kathy Metaxas talking about how to deal with the new patient. We have Jesse Green on the same topic. We have Dr. Michael Stubbs on TMJ and sleep apnea, Andrew Dillon, and oral surgeons. So we have a whole array of specialists who come in their special fields. And just about every module, I think it's 6 out of 8, we have a hands-on component as well. And what else is included? Well, I put all this stuff in. 21 days of face-to-face lectures. We have pre-course videos and reading material. We have post-course resources. We have 6 evening webinars. We will have a full recorded online, which is complimentary to everybody. And we also have been accredited for a postgraduate diploma in orthodontics. So you can go down that stream as well, which is exactly the same program, but you just have to do a couple of tests and treatment plan and cases to present, etc., etc. We've got all these learning and admin resources. We've got an optional in-office program. We can actually come into your office and consult with you and help. We've got treatment planning services. We've got a digital indirect bonding service if you want to use it. You don't have to. The way we teach you, it is not based on any particular system. You could use chicken wire for all I care. But we'll tell you what we use and why we use it, but you can use any system you want. And most important, in the future, we're going to have a full ongoing membership program so you can still stay in touch with ongoing learning. But at the end of the day, it's the mentorship that I can provide you and my group can provide you, which is going to make it really worthwhile for you. So on that note, I know we've gone a bit long, so I want to say thank you very much. You've been a great audience. If you want to contact me, you can do so on email at jeff@orthoed.com.au. We've got a lot more information about our training at www.orthotraining.com.au. But I know this could be a really big investment. I know that there are lots of questions, and I'm happy to answer them now. But I'm happy to spend 45 minutes with you on what we call a discovery session to make sure that we are the right fit for you in what you want from the training. And obviously, we want to make sure that you're the right fit for us too. So thank you very much for your time. I know I've taken a lot of your time tonight, but thank you very much. And I hope that you've benefited from this webinar. And please feel free to email me, jeff@orthoed.com.au, and I'm happy to do a discovery call and really find out what you need, what you require, and what we can do to help you in taking orthodontics to the next level in your practice. So thank you very much for your time. I'll see if there's any questions here, but my question computer has gone off. Any questions from anybody that I can address? Well, I've got a lot of people saying thank you very much, and I'm glad you enjoyed it, and I hope that was of some benefit to you, and maybe just sparked a little bit of interest as to what you need to look for in orthodontic education, if that's what you want, if that's the path that you want to go down. But I suppose just to finish up, in these days where the competition is so great, I think you have to have orthodontics as part of your armamentarium, because it's no different. It's like practicing dentistry without being able to do endo, practicing dentistry with referring out all your perio. I think those days are gone, unfortunately. So hopefully we may be able to help you. And if not, maybe somebody else can help you. But I think it's really important that we look at orthodontics as being an essential part of your practice, an essential part of growing your practice. So once again, I say thank you very much, and we'll be having some other webinars later on, and I look forward to having you on board for those. So thank you very much.